Okay, so this one is the cardiovascular system. We will first talk about the heart. Cardiovascular system include cardio, which is the heart, and the vascular, that is the vessel. So we will first talk about the heart portion, and then the next one we will talk about the vascular system, and then we will talk about regulation of the circulation as well as the blood pressure. So with this heart portion, we will the material coming from the Guyton and Hall, this textbook, as we already mentioned about, and it's in chapter 9 to 13. So because of the limited time, we will only focus on the most essential concept in this cardiovascular system. So you guys will need to learn about the cellular, the major portion of the cell in the heart, that is the cardiomyocyte. This one basically is a muscle cell, is a type of muscle cells. And so when you learn about, earlier we learned about the skeletal muscle, a lot of concept can be used to here. And then all the muscle cells in the heart are connected in a way that they all contract together. So we will start to learn about the contraction cycle, the systole and the diastole in both atrium and ventricles. Then we will talk about how is that cycle is initiated from the SA node through the conduction system to control the muscle contraction. And then we will talk about the EKG. In the very end, we will also mention about the major heart diseases. So this is the very basic portion of the heart. So I assume that you have some kind of like anatomy background about the heart. If not, at least you need to know something very basic, which is that there are 4 chambers, left and right, atrium and the ventricle. So at least you need to know that. And you need to know that how are these chambers connected to each other, as well as how do they connect with the vessels. So in very basic concept you need to have is that this blood coming from the body get into the heart to the right atrium, and then the blood go into the right ventricle. Following that, blood go into this blood going back to the heart has less oxygen, so it's the oxygenized blood. So it's basically coming from the vein. And so you need to know that this the big vein going to the heart are vena cava, superior vena cava, and inferior vena cava. One from the upper portion of the body, and the other one come from the lower portion of the body. Yeah, so this is vena cava. And then going to the right atrium, to the right ventricle, pump it out to the pulmonary artery. This pulmonary artery will go into the lung to get oxygenized. Then this oxygenized blood go back to the heart, to the left atrium, left ventricle. Then the left ventricle provide high pressure to push the blood through the aorta to the entire body. So we have these 4 chambers. You need to know how its blood flow from right atrium, right ventricle, then the pulmonary, back to the left atrium, left ventricle, then the systemic circulation. So you need to have that kind of idea that the sequence of the blood flow through these 4 chambers. You also need to know that there are valves get involved. The purpose of the valve, we have 4 valves. 2 are between the atrium and the ventricle. One is the left, the other one is right. We also have valve from the ventricle to the blood pressure, to the artery, from the right ventricle to the pulmonary artery, and also from the left ventricle to the aorta. The major purpose of the valve is to prevent blood backflow. So when we squeeze it out, we want to make sure that it's the blood going from only to the one direction, and it's not going to be backflow. So that's the purpose of the valve. So the very beginning, we need to know about this cell, this cardiomyocyte. This is the major player of the heart contraction. We need to have this muscle to contract. Cardiomyocytes is one type of the muscle. We basically briefly mentioned about it earlier in our previous lecture in the muscle and the unit of the muscle. And we did not talk a lot about the cardio yet. We will talk about it here. But we did talk about the skeletal muscle. So the contraction, the mechanism is very much the same. You need to have a calcium going in, binds on the troponin C, and then you will have myosin and actin interaction to cause muscle contraction. So it's very much the same. Cardiomyocytes, like the skeletal muscles, are all striated muscle. So this is different from the smooth muscle. Smooth muscle is not a striated muscle. So a very simple question is like, which one is not striated muscle, or which one is striated muscle? You can choose that. Cardiomyocytes and the skeletal muscle are striated muscle. So that's something very similar. These two have a lot in common: the skeletal muscle and the cardiomyocyte. There are 2 things, probably 2 or more, that's unique in cardiomyocyte. One is that, let me see, maybe it's down here. Yeah, is that in the skeletal muscle, each muscle is a muscle fiber, and these muscle fiber are controlled by the neuron through this neuromuscular junction. So acetylcholine binds on the nicotinic acetylcholine receptor in the skeletal muscle to contract each muscle cell, to each muscle fiber. Cardiomyocyte is different. Cardiomyocyte, you don't see that neuromuscular junction. So you don't see that muscle contracted, excited by nerve. This muscle, the entire atriums, probably has hundreds to thousands, or even 100, like millions cells in the striatum or in the ventricle. So in entire organ, in each chamber, these muscles are not isolated from each other. They are connected in a way that they will contract all together. So you just need to excite one muscle cells. These muscle cells will generate action potential. Then action potential will propagate through this ion channel. Sorry, this gap junction. All these cells have the interior portion are shared with each other through this gap junction. So we have the gap junction here, gap junction. So all these cells have, once the ion enter into the cell, it will propagate, it will diffuse through this gap junction to the neighboring muscle cells, so that the entire organ will get excited. If one have memory potential change, due to the action potential that will trigger memory potential change will propagate through this gate junction to the neighboring. So that's one thing very unique in the heart, that the entire heart, the muscles are connected. The two atriums basically will each chambers are contract together. Left and right atriums will contract together. Left and right ventricle will contract together. That insertion that form a unified contraction is due to the gap junction connected between muscle cells. So that's one thing very unique, that you don't see individual muscle contract independently from other muscle cell. You will see that all the muscles will get excited, will get contract all together. It's not because that they have individual nerve innervation. It's because that all these cells share their ion distribution through the gap junction. So gap junction is the unique portion of the cardiomyocytes. So we have that idea here. Also, they have this transmembrane protein complex called desmosome, and that hold two cells together. Basically, that is the adhesion mechanism to put all these muscle cells very close to each other. So gap junction is the channel to allow the ion to be diffused from across the entire organ, and that allows the action potential to be traveled very quickly from one cell to the entire organ. And that allows the contraction, a unified contraction of the entire organ. Now, the action potential is also a little bit different in the cardiomyocytes compared to the skeletal muscle. In the skeletal muscle, we learned that skeletal muscle will have the depolarization and the repolarization, right? Depolarization coming from the sodium channel, open of the sodium channel. Repolarization is the open of the potassium channel. And that's very typical action potential. But in the cardiomyocyte, the action potential has one thing unique, which is in addition to the depolarization and repolarization, it also has this elongated plateau period. So phase 0 is the typical depolarization, sodium channel open. Phase 3 is the repolarization, that potassium channel open. So these two are very typical. One thing unique is the phase 2. Here we have what? We have the calcium channel open. This is the slow open L-type voltage gated calcium channel. This one open will allow calcium to go into the cell. So that will make the action potential has this prolonged depolarization caused by the calcium influx. And that is the calcium that cell need to conduct the contraction. So here we have the I want to also mention about the time here. So I want you to pay attention on that. Here we have this prolonged plateau of the depolarization And that takes about 200 milliseconds, which is about 0.2 second. And that 0.2 second is a time when calcium go into the muscle, and it's also the time when muscle contract. So this gives you an idea that the muscle contraction take about 0.2 seconds. And that also gives you an idea that because the entire organ contract together, your chambers contract each time it takes about 0.2 seconds. Okay, so that's the idea, you know, that when it contract during that systole, that contraction, it basically takes about 0.2 seconds. All right, so that is the very basic cardiomyocyte, the contraction mechanism, and the action potential. Now let's talk about how is this heart. The major feature of the heart is to serve as a pump, and this pump is induced by a rhythmic impulse initiated from this SA node. So here is the cardiac conduction system. So you can see that these are the heart, and you can see that basically we have like a signal transduction pathway from initially from the sinoatrial node, SA node, to both left and right. You can see this um, like a shadow arrow pointing to both right and the left atrium. So when SA generate an impulse, this will autonomically generate a rhythmic impulse. That rhythmic impulse will be delivered to both left and right. And so that will cause a contraction in the left and right atrium altogether. Atrium and the ventricle are separated by the fibrous tissue. So the muscle are not connected to each other. They are separated. So the contraction will only propagate to the atrium, both left and right, but not ventricle. And then this contraction, how much time this contraction will last? Because the action potential, the plateau is about 0.2 seconds. So this contraction in the left and right atrium will take about 0.2 seconds to complete this contraction. And during that contraction, signal will propagate to the AV node. Then AV node will propagate through this bundle of his and to left and right Purkinje fibers to both left and right ventricle. And there it will be a delay from the AV node to the left and right ventricle. That delay because we need to wait until atrium complete its contraction, which is about 0.2 seconds. Then the signal will send to the ventricle to trigger the next contraction in the following contraction in the ventricle. So we have the atrium contraction first, signal in the same time during the contraction, signal propagate to the bundle of his Purkinje fiber to the ventricle, then ventricle contract. The time lag of this ventricle contraction is about 0.2 seconds. So here, 0.2 second contraction here, signal transduction, ventricle contraction. So this is the conduction system. So among all these conduction systems, the most important one is the SA node. SA node generate this rhythmic impulse. So this is a natural pacemaker in our body. It initiates this impulse. This impulse will send the fiber. The SA node is located, anatomically, it's located in the right atrium, and it has the fiber. These SA nodes, these fibers are not nerve fiber. They are the muscle fiber. It's just they don't have the contractile. They don't have the myosin to conduct this contraction. But they have the capability to generate action potential like all other muscle cells. And that action potential will travel to both the left and right atrium, eventually lead to the AV node. AV node is located in the atrium as well before it enters into the ventricle. So here is the AV node. AV node, atrium ventricular node is located in the atrium wall behind the tricuspid valve in the right atrium, And then it will, here you can see that the SA node send fiber to the AV node. When they send fiber to the AV node, the signal has some delay here, 0.03 seconds. You don't need to worry about this specific number, 0.03, 0.12, and 0.16. All you really need to know is that from the AV to the, through these AV nodes, around this AV node area, there is a delay. It's a purposely delay to delay about, here it says 0.16 second, roughly about 0.2 second when the signals sent to the ventricle, it will be around 0.2 second. And that major delay is here around the AV node. So the question, if the question is that during the cardiac conduction, signal conduction system, which portion has the major delay? Your answer should be around the AV node. And that delay is critical because that delay allows atrium to complete its contraction before the ventricular contraction. So this one is the picture showing you that the entire electric conduction system in the heart. The pacemaker, the initial portion is the SA node, sends signal to both left and right, signal transduced to the AV node. AV node has about 0.16 second delay, which is needed because we need to wait until atrium finish its contraction. Then AV node sends signal through the his bundle to the left and right Purkinje fibers to the left and right ventricles. So this is the conduction system. So you need to, the quick question would be, give me the sequence of that conduction system. SA to AV to bundle of his to Purkinje fiber. So that's the right sequence. Now, at this point, you should know that the contraction sequence of the heart, what we just say is the signal conduction, and then that conduction basically match the contraction sequence. So when the SA node sends signal to both left and right atrium, both left and right atrium contract together. It's because that all these muscles are interconnected to each other and will be excited all together. right atrium will contract together, even though that contains a lot of muscle cells, but these muscle cells don't contract independently. They contract together, and that is called a sensation. We have the atrium sensation because these two contract together, followed by the ventricular sensation because these two contract together. So if I ask you the contraction sequence, you will give me left and right atrium contract together, followed by left and right ventricle contract together. That is how our heart functions. Blood flow from the right atrium to the right ventricle and go back to the left atrium to the left ventricle and go to the systemic circulation. That is the flow of the blood. But the contraction-wise, it's right and left atrium contract together, followed by the right and left ventricular contraction together. Another thing you need to know is that the conduction pathway, even though the SA is atypical, is a nature pacemaker, is the one to induce the rhythmic impulse. However, what you really need to know is that it's not the only one. SA node can generate impulse, but all other portion of this conduction pathway can also generate the impulse. It's just that SA generated impulse fastest among others. So say like if I ask you that who wants a candy, then everyone raise a hand, right? And the very first one, the very fast one, will get a candy. And that's the thing here in the cardiovascular system. They all can generate the rhythmic impulse, but the SA nodes is the fastest one that it generates the impulse at a rate about 70 to 80 times per minute. And when they generate that rate, it becomes a dominant rate. So even though other portion of the conduction system has the capacity to generate the rhythmic impulse, they are suppressed by these SA node because they don't have the chance. They will get excited by the SA nodes and they will enter into this refractory period. They just don't have the chance to show that they have that capacity. However, one thing you need to know that if the SA node for some reason fail to generate action potential, then the other portion of the heart would lose that kind of dominant influence, and then they will have the chance to show their rhythmic impulse. So it's possible that patients may have already lost the SA node impulse, but they just don't know because they still generate heart rate and still provide a contraction, but and that contraction is sufficient to meet the daily life needs. So as long as they don't do something very heavy loading or run or any labor works that require a lot of blood flow, they probably won't even notice that their SA node has already failed to produce that rhythmic impulse. So that you need to know that all these conduction systems can generate a rhythmic impulse. It's just the SA node is the fastest one. All right, so I want to mention about something that's more clinical relevant. That is the EKG. So the figure showing you here is a very typical EKG. And basically, when we measure EKG, we put the electrode on the body. It could be in the arm or it could be in the leg. And what we measure is the current flow through that electrode. So how is that related to our heart? This basically is related to the action potential. So we know that the entire atriums and the ventricle, we have two insertion. Atrium has muscle. Each muscle generate action potential, depolarization, plateau, repolarization. And because we have hundreds to thousands of the muscles contract together, so their depolarization will provide a lot of current or signal propagate through the skin, through the body to be detected by the electrode. And what we detect is the change. So say we have the heart generate one action potential. This is a representation of all other 100,000 because they all generate this action potential at the same time. So this insertion, a group of muscle generate this action potential, it will be very much like an earthquake. So if you drop a rock on the ground, it will generate a little wave through the earth, and it should be, and that's it, right? And probably nobody noticed it. But if you consider that's not just single rock, but a lot, hundreds, thousands of the rock hit the ground all together, you probably will generate a wave strong enough to propagate further away from that epicenter and to be detected by the detector, right? So it's very much like the wave, very much like an earthquake. So here we have a stable memory potential, and all of a sudden it generates all of a sudden it change. That voltage change is very much like an earthquake. It generates a wave, and that wave can be detected by the EKG. And in the same time, it's stabilized. When it's stabilized, it doesn't generate wave. It doesn't disturb the environment. So we don't detect another EKG, but signal will be repolarized. The action potential will follow a repolarization, and that bring back the memory potential. That generate another wave, propagate to the remote area of the body, and that can be detected by another EKG. So the EKG detect the change of the memory potential, the change, either the depolarization or the repolarization. So that's the EKG. What's the most important portion that you need to know is that typical EKG has this P, QRS, and the T. P is the depolarization because we first have the atrial contraction, atrial depolarization, followed by the ventricular depolarization. So we have the atrial depolarization, the P wave. The beginning of that P wave indicate there is the depolarization of the P wave, of the atrial muscle. And this one will last for about that contraction will last about 0.2 seconds. Then the signal will then the ventricular muscle will generate its depolarization. Ventricular muscle depolarization will cause another wave. This wave is called a QRS wave. QRS is the ventricular depolarization, and that will stabilize and then a repolarization, ventricular repolarization will be detected by a T wave. So we have the P wave, atrium, depolarization. Eventually atrium will repolarize, but atrium, if you happens to know the size of the heart, atrium repolarization overlap with the ventricular depolarization because the atrium, the mass of the atrium is much smaller than the mass of the ventricle. I remember it's about 1 to 5, like the size of the atrium is about uh, uh, 1/5 of the size of the ventricle. So even though that is a combination of atrium repolarization and the ventricular depolarization, what we really measure here is the ventricular depolarization. So QRS usually is a wave to indicate the ventricular depolarization. And then T wave. So that is something that you need to know. Here, a typical quick question would be, what's the meaning of the P wave? The answer is the atrium depolarization. What's the meaning of the QRS? That's the ventricular depolarization. What's the meaning of the T wave? That is the ventricular repolarization. So that's the EKG. And this EKG, why is that EKG important? EKG, okay, so here is a typical EKG that these are some example that we collect in the hospital, not in the hospital, but with the school of medicine students. So you can see that the EKG, the units, for example, we will see not just the EKG from different leads, lead 1, lead 2, lead 3, AVR, AVL, AVF. Here we are not talking about all these different leads. If you are interested, we can probably talk more about it. But I remember that later you will have another like a course. I remember it's a cardiopulmonary physiology to talk about more clinical aspects of the cardiovascular system. So we probably will learn more about this one. But just very briefly, that you can see that the x-axis has a units of 25 millimeter per second. So you get the idea that the time. So for example, from here, you can see PQRS, PQRS, PQRS. And from each RR interval, you get an idea that the heart rate, right? Because this time is how many squares, and then you can get the time of between between this R wave and this R wave. And so you can get like the repeat of this R wave, you can get the idea about the how many beats per minute, right? So that is your heart rate. And you can also get in the y-axis, you can see that how many 10 millimeter per millivolt. So you can get the idea that the strength of that wave. And by using this RR interval, you get one very important aspect, that is the rhythmic, to see that if it's regular. If you see this duration is very much regular, you can see that this heart is pretty okay, you know. You can also see that in the very beginning, you have this little square. This is the like a calibration that from the beginning to the end, it should cover about 5 millimeter, 5 small square from the bottom to the top should cover about 10 millimeter, 10 small squares. So just give you an idea that if you have never see any like a clinical round EKG, this is what you will get. That multiple leads, and just by using these units, you can get a lot of calculations. You can get the RR interval, you can get you can kind of estimate how well this peaks repeats itself through the entire time course. So why do we need to have the EKG? What is that clinical relevance? The clinical relevance has several. So one is here I list 3 major factors that we commonly use to get from the EKG or ECG to see whether this heart is healthy or not. So the very first one is the PR interval. The P here is the PR interval. This PR interval indicates the time between atrial depolarization and the ventricular depolarization. And this time typically is around 0.2 seconds, because that is the time that we need to have the delay to allow the atrium to complete its contraction. And you need to know that that delay is purposely delayed. If we don't have that delay, the signal contraction is way faster, too fast. And then the heart contraction blood flow gonna be disturbed. The problem is not that it is transduct too fast. It's because of this purposely delayed, the signal is purposely kind of like weakened through that transduction. And for some patients, that transduction may be accidentally blocked. So AV doesn't really transduct signal to the, SA doesn't really transduct signal to the AV. And so we will sometimes see the patient with that delay way too long. It's way more than 0.2 seconds. If it's more than 0.2 seconds, say this delay is way too long. What happens is that we probably don't see this QRS at all. We have P and then another P, or we have the very long delay, P, very long, then QRS. If it's longer than 0.2 seconds, then we have this 3rd-degree heart block. Indicates that transduction doesn't really go through well. So that's the PR interval. Another important one is the RR interval. As I mentioned earlier, this RR interval is the one to estimate the heart rate. And if this RR interval present in a very regular pattern, then we say this rhythm is very good. Otherwise, if it's fast, slow, the duration is changing rapidly throughout the time course, then we say this patient has a arrhythmia, that the rhythm is not normal. So our interval is also important. That is one to measure to estimate the heart rate, as well as the repeatability of the heartbeat. Another common measure is the ST segment here, ST segment. This ST segment typically is a little bit elevated, moving upward, not elevated, but moving upward. If you commonly see not like this perfect flat, it will be a little bit upward. But if you see it elevated a lot, like elevated a lot, then it's a sign of the infarction, that there are ischemic damage ischemia means that lack of the blood supply. So it means that perhaps the blood provide the blood into the heart. Heart muscle is affected. Usually it's the coronary artery. We will talk about the coronary artery in the next topic, in the next chapter, when we talk about the vessel. But say that artery is blocked, and then there is no enough blood flow to the heart. And that is a very typical cause of the heart failure or heart disease. And that we typically see that ST segment, if it's an infarction, we will see it's elevated. So that's the ECG diagnosis. All right, so we have the knowledge about the signal, electric signal from the SA node to the AV node, and to cause the contraction of the atrium followed by the ventricle. And that can be measured by the EKG through the P, QRS, and the T to non-invasively seeing the pumping of the heart. Now the next topic is to talk about this cardiac cycle. With this one, we will talk about the during each cycle, we will have the diastole. Diastole means that the muscle relax, and the systole means that muscle contract. Each cycle is initiated by the rhythmic impulse provided by the SA node, and each cycle is completed by the blood going from the atrium and pumping out from the ventricle. So that is the cycle. So we will talk about that cycle here, cardiac cycle. So the cardiac cycle begins by the atrium. Remember, in the EKG, P, Q, R, S, and the T. So it's a P. P is the beginning of everything. And P is the atrium depolarization, so atrium contraction. So let's start by talking about atrium. Atrium, so as you can see here, blood go into the right atrium as well as the lung pulmonary circulation to the left atrium. They go into the right and left atrium. They go in when everybody is relaxing. So say that the entire heart, when they contract, it only takes about 0.2 seconds in the atrium, 0.2 seconds in the lung, in the ventricle. And there is a large period of time that the heart is not contracting at all. Because say, if the heart rate is 60, make it easy, 60 beats per second, per minute. It means that each beat takes about 1 second, right? 6 beats per minute. Each minute has 60 seconds. So each beat is a second. And during that 1 second, contraction itself only maximally take about 0.4, atrium 0.2, ventricle 0.2. So there is a period of time, say 0.6 seconds. Both atriums and the ventricles are relaxed. And during that relaxation, that diastole for both atrium and the ventricle, blood freely going in because there's no contraction, there's no pressure. So blood freely enter into the atrium as well as the ventricle. So before any contraction, blood fill up the ventricle through the atrium to the ventricle for both left and right to fill it up to about the 80% of the total filling. And then following that, then we will start to have a P, right? P wave, atrium contraction. That atrium contraction will contract both left and right. That will make it about, let's see, use pen. So in the beginning, it will fill up to about 80%, right? 80%, 80% here, 80% here. And then the contraction will fill another 20% to make it 100% full. So that is the atrium, diastole, and the systole. During the atrium diastole, it's also the ventricular diastole. That blood already filled up to about 80%. And then atrium systole will eject another 20% to make it 100% full. So that's the atrium. Now, let's move on to the ventricular. Ventricular, it will be about 0.2 seconds later after the atrium depolarization. So this one is a diastole, atrium diastole, ventricular diastole. Then atrium eject 20%. Then the ventricular systole, ventricular will start to contract. Ventricular contraction, when it contracts, it will generate, because the space becomes smaller, it pushes the fluid, and the fluid will first, here we have the valve going to the artery, left is going to the aorta, right is going to the pulmonary artery. Let's say the aorta. Aorta has a pressure. Aorta pressure is a pressure that we measure in the arm, very similar like that. So the pressure is about, say, very typical one is 80 to 120, right? So you will never get the blood pressure to 0. The minimum will be about 80. So here we have the 80 here, 80 atrium, 80 mmHg in the aorta to push it. And so when the ventricles start to contract, it has to be high enough to push the blood out, but it's not. In the beginning, it's not high enough yet. So instead of pushing it open, it will first close this one. It's high enough to close the AV valve. And when it closes it, while before opening up the semiluminal valve, the valve to go into the artery, that pressure increase the ventricular contract while the valve are all closed. So the size remain the same, although the pressure continue increase. During this time, we have the isobarometric contraction. We have the contraction, but the size remain unchanged because all valves are closed. So that's the very first one. We have very short period of the isobarometric contraction. And then blood pressure continue building up. In the left, you need to build up above the minimum pressure in the artery, which is about 80 mmHg. In the right ventricle, it's about 8 mmHg to push the blood into the pulmonary artery. So you need to be above that level in order to push the blood out. So next one is the ejection. When the blood pressure is high enough. So here is the isobarometric contraction. The ventricular pressure increase, but not high enough to push the blood out. Here, the ventricular pressure high enough. In the left, it's above the aortic pressure. It's about the minimum one is 80 mmHg. In the right, the pulmonary artery, the minimum one is about 8. And when the pressure is high above those, then the blood will be ejected. This ejection can be viewed in 3 periods. The first third eject the most. about 70% of blood to be ejected in the first third. Because of that fast ejection, this period is also called the rapid ejection. So the first third of the ejection period is called fast ejection, rapid ejection. The next 2/3 eject the remaining 30%, and this is the period of the slow ejection. Totally, we don't eject the entire blood. We don't. We almost eject about 60% of the blood in the ventricle. So even though it ejects, it doesn't really eject everything. It's not emptying the entire ventricle. There is about 40% blood remain in the ventricle. So that ejection fraction is about 60%. It's called the ejection fraction. That portion to be ejected out, that percentage is called the ejection fraction. So that's the ejection. And then contraction will be end. That's the end of the systole. Then the ventricles start to diastole, start to go, that period take about like 0.2 seconds. And then the ventricles start to relax. And when it relax, like here systole, when it relax, the blood pressure decrease. When the ventricular pressure decrease, the first thing it does is because when the pressure is lower than the vessel, the artery pressure, this valve will be pushed back, will be closed. So when the ventricular diastole, the first thing it will see is the pressure decrease while all these valves are closed. And so we have, because all these valves are closed, the size of the ventricle won't change. So we have this isovolumetric relaxation. And following that so here is the pressure decrease. And then when the pressure continuing decrease, it will be lower than the venous pressure. And then this valve will open. And during this time, we have both atrium and the ventricular diastole, the blood continue flowing. And then that go back to the very first one. This is the previous slide that all the atrium and the ventricle are relaxed. And we begin another cycle that everybody relaxed, blood already filled in about 80% of the blood in the ventricle. So that is the cardiac cycle. Any question? Easy, right? All right. So next one is there are some important measures that this terminology you probably will hear, very typical terminology you hear in the cardiovascular system, that we have the term called end diastolic volume. That is the volume that how much blood enter into the ventricle. So the total blood, the end of the atrium contraction that eject all the remaining 20% into the ventricle. And then that will make the end of diastolic volume. So this amount is about say 120 milliliter. We also commonly hear the stroke volume. Stroke volume is that each time blood eject out of the heart into the body. So the amount is 70. So you can see that the heart each cycle receive about 120 milliliter, fill up to about 120 millimeter, but it only ejects 70. So it doesn't really fully eject all the blood in the heart. And so the remaining is about 40 to 50, which basically is the end diastolic volume EDV minus stroke volume SV is the end systolic volume. That when we systole, eject it, we have something remain. And here we can also get the ejection fraction. The ejection amount is 70. The total we have is 120. So 70 minus 120 is about 0.6. So this one is the ejection fraction, EF. Another very important one is the cardiac output. So here, cardiac output is the shock volume, that amount of the blood ejected out of the heart each time, times the heart rate. So HR times heart rate, HR, heart rate times stroke volume is the cardiac output. And so if we want to get an idea that how much blood provide into the body, we need to know how fast the heart pump, that is the heart rate, as well as how much the blood pump each time, that's the stroke volume. This equation is a must and a must that you must memorize it. Cardiac output equals stroke volume times heart rate. You will see it in the quiz, in the exam, okay, I guarantee you. And the quiz will be very much like, which one is accurate? CO equal HR times SV, heart rate times stroke volume, or HR equals CO times SV, etc. The one is CO, the correct one is CO time equal HR times SV. So this one is a must and must. Cardiac output, stroke volume times heart rate. Another very important concept in the heart is called Frank starting mechanism. This means that the more blood go back to the heart, the more it can pump out. So the stroke volume, the more it pump out, depends on how much blood go into the heart. So this is why that the venous, this is the heart, the blood going to the heart is the amount, this venous, this is called a venous return. So the venous return, the more you have with the venous, from the vein into the heart, venous return, the more heart can pump out. And that is why that when you run a marathon or exercise, right? And you need your blood, you need your heart to pump blood into the body. And the way to keep it running is to have a good venous return. And that venous return, a lot of that coming from the muscle, because when our body muscle, the leg, the arm, when you keep walking, that muscle movement can squeeze blood back to the heart. It's called a muscle pump. And that's why that when you run a marathon, even though you reach the finish line, you want to rest, you should not just sit. You should get some water to refill your fluid in the body, and you should keep walking. That walking is a kind of the muscle pump to pump the blood back to the heart. And that is essential to provide the venous return needed for this stroke volume, for the blood to pump out from the heart. So the venous return, and this mechanism is called a Frank starting mechanism. All right. So so that is the cardiac cycle, and the cardiac cycle. We learned about how blood go into the atrium and the ventricle, how is diastole and the systole work together to pump the blood out. Another thing here is I want to give you a little bit like get your attention on the valve. Here we have 4 valves. One is the AV valve, and 1, 2 are AV valve. We have 2 AV valve, atrium ventricular valve. We also has the semilunar valves. Those are the valve from the ventricle to the pulmonary artery or the ventricle to the aorta. So we have the 4 valve. The valve is to prevent the blood backflow. The AV valve prevent the blood flow back to the atrium, and that is the time it will be closed during systole when the ventricle are contract. It prevents the blood back to the atrium. As for the semilunar valve, this valve to close prevent the blood go back to the ventricle. So when the ventricle is diastole, when they are relaxed, this valve close to prevent the blood back to the ventricle. So easy question is that which one is closed during the systole? AV valve is closed during the systole. Which valve are closed during the diastole? The semilunar valve are closed during the diastole. So that's also another quiz question, okay? So you have this quiz question for your exams, and those are the ones that you need to memorize. It's not necessary to memorize. If you have a picture in your brain, you kind of will get the idea that which one is more accurate. And these valves are also related to this unique like muscle tendon structure. This is the pupillary muscle are very important to hold this valve to prevent its backflow, especially for this AV valve. The reason is that this is valve closed during the systole. So when the heart contracts, generate lots pressure, and that is the one the valve need to hold, be able to hold it to prevent the leakage, to prevent backflow, and that is the one that when we have the heart disease, the muscle is injured. This is the valve that will be the vulnerable one to get leakage. Okay, so this valve is holded in the healthy heart. We have this pupillary muscle connect with the chordae tendon to hold this valve to be stable here and to prevent the backflow. If unfortunately, if this muscle or tendons are injured, we will have the backflow. This backflow, this leakage is called regurgitation. Okay, so you need to know this term, regurgitation. Regurgitation is the leakage of the valve, and it also referred to the backflow of the blood. In the end, I want to show you the importance of this topic. This one showing you the top 2 leading cause of death in America, okay? And you can see that heart disease and the cancer are the top 2, the leading 2 cause. This, as you can see, this one is about 2010. These 2, the top 2 cause death is remaining true until about 2017. The latest one I saw is 2017, and these 2 are remaining the top 2 leading cause of death. But we all know that the reason we have the virtual classroom is because the COVID-19, and I bet that by 2020, we probably has COVID-19 on top of this one here. But regardless, heart disease is the leading cause of death. And you can see the trend is going down, especially compared to the cancer. Cancer is very troublesome. We still don't have very good understanding and good way to manage it. We have some improvement, but still a lot to do. But we need to know that cardiovascular disease, heart disease, is very important because this is one that affects is a major disease in our society. So since this one is so common, we need to have some very basic idea about this heart disease. A very typical one is called atrial fibrillation or atrial arrhythmia. So what this one is that one that I mentioned before that even though if we don't have the atrium contraction, we can still live pretty much okay. And that's the situation that with patient with the atrial fibrillation and atrial arrhythmia. So you can see that here is the normal heart SA node cause contraction to the both left and right atrium, and the AV node signal to the left and right ventricle. So we have very good PQRST. But with atrial fibrillation, there will be no obvious P wave. It's because that either the muscle in the atriums are injured, or is that SA node signal is not transduced to the atrium very well. So we have, if we do the EKG or ECG, we can see that there's no P wave. And we have the irregular ventricular QRS rate. However, this patient will have no symptom because the ventricles still contract and produce the blood. We don't need 100% blood, even though here blood probably fill up to about 80% only, but for the normal life, people won't feel anything about it. Even though this one doesn't really provide the patient like acute heart disease, this one has tendency to build up thrombosis, build up the thrombus, because this blood here are stagnant, that they don't flow as smooth as possible. So this stagnant blood will provide the environment for this clot factor in the blood to start to react and to build this clot and form this thrombosis. And that thrombosis will eventually flow through the artery and cause the ischemia somewhere in the body. It could be in the brain, it could be in the heart. So this one has that kind of will increase the higher risks for other vascular disease. So this is the atrial fibrillation. A more devastating type of the heart disease is the heart failure. So this one means that we have the local heart muscle damage, and that heart muscle damage will cause this entire insertion become incompetent. That for the healthy heart, every muscle cells are interconnected with each other through the gap junction. But now, if the muscle is injured, they may fire randomly, they may generate action potential randomly, and will make this entire sensation become ineffective. And then the blood, the vessel, the heart cannot pump enough blood into the body. This heart failure can be distinguished to two types. One is called left side heart failure. Left side, as you can see here, is the blood going to the body. So here is the oxygenized blood. That blood coming from the lung, pulmonary, receive the oxygen, so blood are oxygenized to the left atrium, to the left ventricle, and then to the aorta. So this is the left side. When the ventricle fail to pump the blood out, this blood will remain in the ventricle, and that will build up the pressure. That pressure is too high that blood cannot go into the ventricle because they don't pump out, they stay here. When they stay here, blood cannot go in. So the blood will remain in the, here is a pulmonary, in the lung. Blood remain in the lung will cause lung filled with the fluid, will fill with the, because of the blood. And so the fluid will remain in the lung, and that will cause the pulmonary edema. You see the patient, you will see the patient that difficult to get oxygenized, difficult to get the oxygen into the lung because the lung is filled with the fluid, short of breath. In the same time, their CO2 cannot breathe out. So we have this pulmonary edema. So that's the left side heart failure. If it's right side, then the blood remain, because blood cannot pump out, blood remain in the right ventricle and the right atrium. Blood remain here, so blood cannot go in. This blood coming from the body, so the body will have fluid. You will see the patient will have their legs, usually their body, you will see that a lot of fluid remain in the body, and that is a sign of the right side heart failure. Left side is also called forward heart failure, very typical one, and that can cause the pulmonary edema. The right side is also called backward heart failure. This is less typical, but this one will cause the fluid remain in the body. So which one has pulmonary edema? Which one is related pulmonary edema? The answer is left side heart failure. So something that you need to, when you see your patients have this symptom, you get the idea that it's not the lung disease, okay? If the person cannot breathe well, it's because of the heart, and you should immediately know that it's the left side heart failure. So that's that. And that is it.